so much insightful and important information.
And that's only from the first half.
Well, Catherine, please continue. I've heard our peers use the term selective targeting in their lectures and publications. What did your speakers say regarding the concept that PFA selectively targets a tissue type?
Yeah, well, obviously PFA can't target a specific tissue type. However, the transmembrane voltage threshold of myocardial cells is lower than other cardiac adjacent structures. Therefore, myocardium is impacted at a lower electroporation threshold. Professor Pürerfellner did a magnificent job explaining this.
Dear colleagues, welcome. My name is Helmut Pürerfellner. I am based in Linz, Austria, in the heart of Europe. And the topic of today for me is to talk about tissue sparing with pulsed field ablation. As you might know, the extent of electroporation and induced cell death is dependent on the field strength and the duration of the applied electrical field. So we might have different effects spanning from no detectable electroporation to reversible electroporation, non-thermal irreversible electroporation, which is the desired energy level, or irreversible electroporation and thermal effects. The pulsed field ablation and electrical field effect in tissue will always be non-homogeneous. So the effect depends on the electrical field strength, exposure duration, on depth and treatment intensity and the dose, and on the distance of the electrode to the tissue. Pulsed field ablation also has a stunning effect with a reversible rim, as you can see here. And pulsed field delivery also has a thermal component at the electrode, as you can see here. PFA is non-thermal, mainly. Yes, it does not kill cells by temperature increase or decrease, but pulse delivery does heat the tissue, the blood, and the medium. And here you can appreciate the PFA temperature profiles in the phi preparation. So, PFA has some thermal effect on the electrode, and the thermal damage represents less than 2% of the volume of the total PFA lesion. Let me now talk about myocyte susceptibility. Cardiomyocytes versus nerve cells, vascular smooth muscle, or esophageal smooth muscle, which are normally preserved. So the transmembrane voltage threshold is different in different tissue specimens. It's low in the myocardium, which is the wanted effect of pulsed field ablation, and it's higher in pulmonary vein, phrenic nerve, esophagus, and red blood cells. So depending on the recipe that we have an effect on the myocardium only if we have the right specimen, the right recipe on board. So let me now talk about the ablation impact on different tissues like the esophagus, the pulmonary vein, and the phrenic nerve. And as you can see here, in thermal injury, it is either radiofrequency or cryo, the esophagus will be damaged or can be damaged. Also the pulmonary vein diameter can be diminished and the phrenic nerve can be damaged, which is not the case in pulsed field ablation. Cardiomyocytes have some of the lowest pulsed field ablation thresholds required to induce necrosis. Accordingly, cardiomyocytes may be preferentially ablated, allowing the sparing of these other tissues. Pulse field ablation, in addition, produces myocyte destruction in the surrounding tissue volume, creating homogeneous lesions, as you can appreciate here. And as you can see here, the Masson trichrome stain of a PFA lesion, there is a preservation of the extracellular matrix and the lack of collateral damage to an adjacent nerve and artery. So let me talk about the pulmonary vein impact in specific with PFA. This is a study that was published 1 year ago, and it shows the consequence of an ablation either by PFA or by RF in the ADVENT trial, where there was a randomized trial, control trial between the PFA or the thermal methods, might it be RF or cryo. And as you can see here, the percentage change in the PV diameter was least in all of the veins using PFA. It was more in the thermal methods and prevailing RF ablation over cryo. But no clinical stenosis was observed with PFA. The next is the esophagus. Esophageal effects with PFA are in the same manner as compared to the nerve or to the diameter of the pulmonary vein. Little effect acutely and no effect chronically. So pulse field ablation preserves the structure of the esophageal wall, whereas radiofrequency ablation, as you can appreciate here, induces injury with necrosis and inflammation and even muscular disruption. So the esophagus is spared clinically in the long run. However, there are some acute effects in the esophagus, showing here in the anterior view of the adventitial surface. However, no chronic damage is observed. So the ablated zone in the esophagus undergoes a reparative process, resulting in nearly normal esophageal parenchyma at 4 weeks, which becomes indistinguishable at 3 months post-ablation. And here you can see some data of a study on the mucosal and submucosal layer. So the histological data measurement of the esophageal wall after non-thermal irreversible electroporation exhibits a tissue-specific dynamics. And at last, the phrenic nerve sparing qualities, which have to be acknowledged. So you can see here in this pig model, an in vivo model, ablation in the superior and inferior vena cava and stimulation of the phrenic nerve measured by an accelerometer here in the abdomen of the pig. And what you can appreciate is that the acute results demonstrated that phrenic nerve function responded to varying levels of PFA and catheter proximity placements, resulting in responses characterized as either no effect or a modulated effect or temporary stunning. But looking at the gross and histopathologic evaluation of the phrenic nerves and diaphragms at the chronic assessment yielded no injury. And this is what you can see here. You have some stunning or even no effect on the nerve. So that all underlines the safety of the procedure, the safety of the energy of PFA.
He does break it down quite nicely, and I appreciate that he highlighted very well the manner in which tissue sparing occurs and its lack of impact on the esophagus and phrenic nerve.